Witam. Dzień dobry. Dziękuję za zaproszenie na konferencję. I'm truly honoured to be here today. That's the limit of my Polish, sorry. Thank you for inviting me. It's been wonderful hospitality. I'm a first contact practitioner working in the middle of the UK, and what I'd like to do is give you a background to the role of a first contact physiotherapist. So back in 2019, the government was struggling to provide enough appointments in general practice for our patients, and they made a commitment to increase the number of annual appointments in general practice by 50 million. And they were going to support that with a recruitment of 26,000 additional staff working in general practice from then until 2024. They called this scheme the Additional Roles Reimbursement Scheme, and it was introduced in England. What they wanted to do was bring a wider team of health professionals working as part of the community teams within general practice. They wanted to provide a tailored programme of care and allow our GPs to actually focus on more of the patients with complex conditions. There were a whole range of practitioners, clinical pharmacists, physician associates, and myself. I was recruited as a first contact physiotherapist with a specialty in musculoskeletal conditions. It had already been proven that these additional roles, these first contact physiotherapists, were already supporting our orthopaedic colleagues by helping with waiting list management. Interface services were introduced, and we already had this this blueprint of care. So it was agreed that implementation sites of first contact practitioners would be tested in England in various locations, followed by a national evaluation. The rollout was supported by an implementation guide based on the model that had been used with our orthopaedic colleagues. And Keele University, along with Nottingham University, led the national evaluation to actually see how these roles favoured. From the evaluation in 2021, 11 of 12 identified success criteria were met. 94% of patients who'd attended first contact physio appointments were likely or very likely to recommend the first contact physio service. And 95% of patients said they had received sufficient information for their self-care. Only 20% of patients went on to see the GP with their musculoskeletal problem within 3 months of that initial contact with a first contact practitioner. On a negative note, only 29% of patients received specific work information from our first contact practitioner. So this allowed us to make recommendations. It had been highlighted that the first contact physio has actually introduced a musculoskeletal specialism into general practice. Many of them had 30 years or so experience of working with musculoskeletal conditions. This had been shown to be advantageous both to patient care, but also valued by our general practice team members. However, public awareness of the first contact role was poor, and more awareness was needed. That training for the staff within the general practice was needed to actually develop resources and signposting for appropriate patients. And it was shown that we couldn't have separate notes. We needed to have the notes embedded within the general practice notes so that everyone was aware of what was being delivered. They suggested that in order to go further with the work, what should be done was explore the barriers to first contact practitioners providing work advice. We didn't really understand why this was happening. And there needed to be an agreement reached. So although there was an implementation guide, many areas across England chose different methods to introduce the first contact role. And there needed to be further evaluation as to whether the first contact model did effectively reduce the workload of GPs. Clinically, what we found that although we might have relieved the musculoskeletal burden, of course the GPs would not be left without unfilled appointments. They would fill those appointments with other patients, but who needed to see a GP. The Chartered Society of Physiotherapy, in response to that national evaluation, created lots of resources to really help and support those practitioners, patients, and our wider team members, so that they could understand more fully what a first contact physio was. Within screens, within general practice, lots of posters, promotional materials, things that could be messaged out, explained what a first contact physio could do, how they can assess the patients, give expert advice, recommend exercises, and refer on to further services if needed. It showed that we were all trying to explain to patients that it wasn't always necessary to see a GP, that actually your first contact physio could help you. So, what happened next? I mentioned that different models were being created across the country. And so what we needed was a standardised approach to ensure governance and safety for our patients. The quality of the service needed to be defined. And we needed to make sure that the practitioners who were being utilised in this role had the capabilities to see and manage these undifferentiated and undiagnosed conditions, and to manage within an agreed scope of practice. And so the roadmap to practice was born. It wasn't without its problems. What they tried to do within Health Education England was create a pathway, and I was really excited for the younger members in our team to have this pathway to be created, this pathway of development, so that our staff could be developed in an appropriate way. There was primary care training pathways, and they hoped that this would supply a pipeline of professionals at the right level of practice to support our general practice colleagues. The staff would have to be supervised, much as a GP trainee has supervision, by a verified first contact physio roadmap supervisor. And it was suggested at this time that prior to entry into primary care, all of these would have been completed. But of course, this was a few years down the line from when actually a lot of practitioners were already in post. So it felt as though the goalposts had changed somewhat. We had a new definition of what a first contact physiotherapist would be. I've mentioned earlier they got to be a diagnostic clinician working in primary care. It had to be established they were working at master's degree level and able to manage those undifferentiated conditions. They had to be recognised through this Health Education England pathway, either via a master's route through our higher education institutes or from developing a clinical portfolio from their wide, vast experience. And they had to refer to our GPs for the medical management of patients with non-musculoskeletal conditions. So how were we going to achieve this when people were already in post? They had, within the roadmap, this extensive 120-page document, we were able to establish what our practitioners needed to do. It was very comprehensive. I put links to these documents just in case you're interested and you'd like to access and see them in more detail. They had to demonstrate, the practitioners had to demonstrate they had that background, knowledge, skills and attributes, and that training had actually been completed. Then there was the stage 2 sign-off, where clinical capability in practice, showing that you could apply that knowledge you had in clinical practice, had been established. And that's where you would get the sign-off from your workplace supervision. As mentioned, it was based upon the supervision of our GP trainees. And we were wanting our GP colleagues to help. But of course, we'd been offered as an additional role to support our GPs, not to actually create more work for them. And so advanced practitioner qualifications were developed to actually support the process. A record of workplace-based assessments were completed with observations of consultations, case-based discussions, and a range of clinical examination procedures to ensure they had that clinical capability. There were lists that had to be completed, as I've mentioned, very comprehensive list of things to do. So what were our challenges? Because of this delayed introduction of what essentially was a really good document being introduced, it was a little too late. We already had agreed contracts in place. We were there to help and support our GP colleagues, and now we were asking them for supervision. So that was tricky. There was confusion and discontent around the roadmap because we had people who'd already been working for many, many years, and suddenly they had to do this backlog of paperwork, it seemed. And there was this lack of supervisors and a shortage of any programs that had been alluded to within the document. But we continued on. And we had great support from our professional bodies, both within NHS England, the Chartered Society of Physiotherapy, and posts were created to actually support this process. We had networks created, regional ambassadors. We were very, very fortunate. And Keele University and our colleagues within the Impact Accelerator Unit worked together with our FCP community. We developed a community of practice and did a training needs analysis to see what our colleagues needed and then provided that expert-led training. So what happened locally? Within our team, so as I say, I work in the centre of England. Eventually, all of our team members completed the roadmap, and from our patient satisfaction surveys, 95% of the patients that we see in primary care are managed independently, with 5% of patients referred to our GP colleagues for non-MSK or red flag investigations. On requesting radiological investigations, we audited in line with national guidance and found that 100% of our radiological investigation requests complied. But a lack of understanding of the role remains. Our patients really do still want to see our GPs. So lots of promotional events, training events for our practitioners continue to be shared. And the NHS is an ever-changing landscape with funding uncertain in some areas for our FCPs. We had very good feedback, both from our clinicians and our patients. As you can see, a GP promoting the excellent clinical care, often signposting the patients if they attend with 2 or 3 conditions and one of them is an MSK, saying, actually, we don't need to see you for that. Go and see our First Contact Physio. And the patients quote there how the First Contact practitioners are a great asset to our GP practice. A regional evaluation of the programme has been investigated more recently, and lots of pointers for success are here, hopefully for other countries to learn from. Long-term stable funding is needed, a structured supervision programme. We were playing catch-up, as I explained in the timeline today. We need data to see what's actually happening and a clear definition of that scope of practice. Lots of visibility and communication within that wider team, and a sharing of good practice within those communities of practice. So FCPs do introduce an MSK specialism and into general practice, and this is advantageous for both our patients and the wider general practice workforce. And our health secretary is currently asking for our patients to help to build the NHS of the future. So hopefully lots of the patients who've seen FCPs will help to inform that future for us. Jean Cuier